for. And then there should be a further record to show how the end user obtained the controlled substance. It'll be in a medical chart, or there'll be prescription records. And so we're able to look at all of those records and determine how the closed system of distribution was maintained, or if something was diverted outside of that system. Next slide. And what we look at too when we're investigating that system is the purpose of a prescription in the Code of Federal Regulations requires that a prescription to be effective needs to be issued for a legitimate medical purpose by a practitioner that's acting in the usual course of his or her professional practice. And so then that responsibility for the proper prescribing rests upon that practitioner. And if we determine that there's something that they've done that's outside the usual course of professional practice, we would start an investigation. Next slide, please. And then to go along with that regulation, pharmacists have the responsibility to make sure that the prescription that they're filling at their pharmacy is legitimate. And so essentially what this means is that pharmacists have the right to refuse to fill a prescription. And I do have a story that I can share with you about a pharmacist that I was working with in Knoxville, Tennessee. I'd gone into the pharmacy with a subpoena to get some prescription information on a criminal case that I was working on. And while I was waiting for the pharmacist in charge to run some reports, 4 individuals walked into the pharmacy in a single file. All 4 had prescriptions for the same drug. And the pharmacist asked them, "What do you want?" And one of the 4 said, "Do you have any Oxy 30s?" And the pharmacist replied, "I'm all out." And so after the 4 individuals left the pharmacy, the pharmacist told me later that there was a pain clinic nearby and that the pharmacy had a steady flow of the pain clinic patients who all received the same prescription. It was the same drug, the same strength, and the same quantity from the same practitioner. And he refused to fill those because he wanted to save his stock for his known customers that he had developed a relationship with. And so essentially he was exercising his corresponding responsibility. Next slide, please. And so to put that into practice for the pharmacist, what they can do is, we recommend that they know their customers, that they know the practitioners in the area that are prescribing, and that they call the practitioner and verify information on the prescription if they think there's something questionable. And pharmacists have the right to say no and not fill the prescription. And what we recommend is if a pharmacist is able to recognize a pattern of prescribing that seems questionable, that they could call somebody. They could call us here at the DEA, they could call a state or a local law enforcement organization, or they could call a state board with a concern. I can tell you in the state of Iowa, over in the eastern part of the state, there have been pharmacies that have called their state and local authorities and have called us here at DEA with regard to prescriptions for promethazine with codeine. That seems to be a pretty popular controlled substance that's been prescribed. And I can tell you, just from an intelligence standpoint, the bottles of promethazine sell on the street for about $900 to $1,000. So I think they found there was a prescription fraud ring that was going around to just their area pharmacies trying to fill those prescriptions, and it was caught by a group of pharmacists. Next slide, please. Sarah wanted to have stories about different types of diversion, and one of the cases that the Des Moines resident office worked involved a practitioner. Dr. Kirby was a dentist who practiced in the Des Moines area, and he was abusing hydrocodone for himself while he was treating patients. And DEA initiated this case after we received a tip from disgruntled employees who worked with Dr. Kirby that were concerned about the patient safety because they saw Kirby was impaired at work. Our investigation included obtaining pharmacy records and video surveillance from some of the stores and parking lots where Kirby had met his patients. We also conducted surveillance on Kirby, and eventually our office conducted a search warrant at Kirby's home and the 2 clinics that he owned. At the search warrants, we found our agents followed Kirby from his home into work, and when he was stopped at the clinic, we found that he was impaired. He had taken some hydrocodone, and that was corroborated by a witness. And then he also had a handgun in the vehicle that he was driving into work that day. So he was charged with obtaining the prescription by fraud, and then having a possession of a firearm while he was using a controlled substance. This case was worked on with the Iowa Dental Board, who presented the case to the board, and Kirby lost his dental license. And then part of our case also included a patient file review by a dental expert who looked at the charts that we seized during the search warrant to see if there was a necessity for Kirby to issue those prescriptions. And based on that review, that's when we were able to determine that he had been prescribing outside the scope of his normal professional practice. Next slide, please. Another case that I could talk about with the poor practice of corresponding responsibility by a pharmacist took place in Kingsport, Tennessee. Kingsport is located in an area of Tennessee. It's the eastern part of the state in the Tri-Cities that includes Johnson City and Bristol, Tennessee. The population is a little over 52,000, and there are 34 registered DEA pharmacies in Kingsport, Tennessee. And if we were to go back to that chart that had the closed system of distribution, manufacturers and distributors are required to report to DEA any sale of a controlled substance in Schedule 2 and any sale of a controlled substance that's a Schedule 3 narcotic, which would include buprenorphine, Suboxone, or Subutex. And those drugs are used for maintenance and detox of patients who have been abusing opiates. And we reviewed the ARCOS information of Mr. G's pharmacy, and that's what prompted us to start an investigation. Mr. G was the owner of the pharmacy. He was about 85 years old, and the pharmacy was open from 6 o'clock in the morning until 6 o'clock p.m. Monday through Saturday. And people crowded in the parking lot and inside the lobby area the whole time during the inspection. It was full. We were there over a couple of days, and we also worked with the Tennessee Board of Pharmacy, and they conducted a simultaneous inspection, if you will. We got there at 5:30 in the morning on the second day of our inspection because we were required to test an alarm system if they had one. And so we got there at 5:30 and noticed that people had started lining up at 5:45 in the morning, waiting for the doors to open up so that they could get their prescriptions for controlled substances filled. Next slide, please. When we ran the ARCOS data, which prompted us to conduct the inspection, we found that Mr. G's pharmacy ranked 4th in overall purchases in the entire nation for buprenorphine products, and they went up to number 2 in the year 2013, and then in 2014 they ranked 1st. They had purchased over 590,000 dosage units of buprenorphine products. Next slide, please. One of the other tools that I like to use when we conduct criminal or civil investigations is going on the internet, and topics.com had some information about Mr. G's pharmacy that kind of played into just the type of pharmacy that it was, and I guess the attitude of the pharmacist or the people that worked at the pharmacy. Next slide, please. So this is just another comment. They talked about getting rid of all of the inventory in the front of the store. The pharmacy was really small itself. You had 4 pharmacy techs, and then there were 2 pharmacists that worked during the day. And the lobby was very crowded, and we noticed a lot of the sundry items that he had not been purchased, or people weren't going in there to shop for other things. They were only in there to get their prescriptions filled. Next slide, please. So then just here's another comment. What we found is that Mr. G was basically what I would call willfully blind, in that he failed to exercise his corresponding responsibility. When we had interviewed him, he admitted that he did not call practitioners to verify the prescriptions. He had prescription logs that showed buprenorphine prescriptions were written by the same practitioner for the same quantity and strength in the same numerical prescription order. And he'd failed to maintain his records or reconcile them because he was too busy filling prescriptions and getting everything filled by the customers that came in. So we had done an audit, and he had not reconciled his Schedule 2 222 order forms. He had not reconciled the electronic order forms. He had not reconciled any of the 3 through 5 records. And so we ended up presenting a case to the U.S. Attorney's Office in the Eastern District of Tennessee for record-keeping violations, and Mr. G is expected to pay some civil fines. Next slide, please. And then another case or example I have that involves diversion involves a non-practitioner. This case was also investigated by diversion investigators from our office. This involves a pharmacy technician who worked at a hospital in the Des Moines area who had access to the automated dispensing machines. And these machines store controlled substances in different pockets on the floors of the hospital. And Mr. Van Cleve was the pharmacy technician involved. He used his fingerprint to log in to the automated dispensing machines, and the pharmacist in charge of the hospital pharmacy was able to run reports for each of those machines, and she was regularly monitoring the access on them and happened to flag the activity by this pharmacy technician because the reports were showing that he'd accessed the machine, but he did not remove any drugs from any of the pockets in the machine, and he didn't put anything in. So he wasn't there working on behalf of the pharmacy to maintain the drugs in the automated dispensing machine. He was just getting into it for his own purpose. And after that was discovered, the pharmacist reported that activity to DEA, and we ended up doing an inspection and getting the reports, and discovered when we had sent the drugs to our testing lab that the material had been adulterated. And because of that, Mr. Van Cleve faces up to 10 years in prison for tampering with the consumer product. Next slide, please. So that's about all I have for just a variety of diversion stories. I just want to make a little plug for the DEA National Take Back, which will take place this year on April 28th. If you were to log on to the website, you or your patients or friends and family members could find a local law enforcement organization that is signed up to sponsor a site where you can take back any of your over-the-counter or prescription control drugs for destruction. And that's about all I have. If you want to go to the last slide, if there's any questions, I'm happy to entertain those at this time.
Wonderful. Thank you so much, Sarah. I think this just really shows the array of ways that people may be diverting medications that we weren't aware of, and just really gives us a good insight into what we may need to be watching for in our own practices, as well as if we're dispensing or working with other prescribers outside of our practice. We did have a few questions come in, so I'll go ahead and entertain some of those here since we've got a little bit of time. The first question is, what does an investigation typically look like, and how are healthcare professionals approached if they will be investigated?
Okay, so every case is different. It depends on how the information came in. Typically, we get the cases that I've worked with that involve practitioner diversion, whether it's a dentist or a veterinarian or a medical doctor. They typically come in from somebody that practitioner is working with, and we try to keep their identity, I guess, safe, if you will, until a time comes when we have put all the puzzle pieces together by running, like the PMP and getting that information and maybe doing a pharmacy survey and maybe interviewing some of the patients to kind of put the big picture together prior to taking it to the U.S. Attorney's Office. And that would be one instance where DEA would be conducting a criminal investigation because there's a violation of Title 21 United States Code, where they've obtained the drug by fraud or they've been distributing it illegally because they wrote a prescription outside the scope. Other inspections that we do that might involve like taking a case to the civil side of the U.S. Attorney's Office, like in the case of Mr. G's, that would just involve actually kind of overtly presenting a notice of inspection to the pharmacy and conducting an inspection based on the records that they're required to keep and looking at the security measures and just how their overall practice is. So we have a variety of tools. DEA registrants are required to abide by those security and record keeping regulations. And because they are registered with us, we can go in and drop a notice of inspection and we have the right to look at those. And so we could do it overtly or we could do it, covertly and build a case without them knowing it. But at some point in time, that registrant, if we find there's some diversion going on, they would be approached. I hope that answered the question.
Yeah, I think that answered it very well. Thank you. That also kind of blends into the next question that we had come in. And that question was, if we were to call the DEA or a state board, do we remain anonymous?
It depends on the situation. In the case with like Dr. Kirby, we kept those two individuals who initially filed the complaint as sources of information until we developed the case that was eventually presented to the U.S. Attorney's Office. And then I think eventually Kirby found out, that two of his employees were involved, but that happened after he was indicted. And we had enough information so that he was going to be criminally charged. And usually when you're charged, we have so much information that there's not really a way that you won't have some sort of repercussion because of that. With the boards, that's a whole other entity. If you were only to send the complaint to the board, all of that information, from my understanding, is kept secret because it just goes directly to the board for board action. And even us here at DEA, we're not allowed to get that information from the board. It goes straight to them. So it just kind of depends on the situation, and we would explain that to any caller that called in with a complaint, and try to keep it as private as possible until there came a time where it was necessary maybe to reveal their identity.
Perfect, thank you. The next question that I have is, in the Mr. G case, was the prescriber investigated as well, outside of just the pharmacist?
We were getting to that. I left that office and I wasn't able to finish the case, and my partner took it over. But yeah, we were able to, through the prescription records, identify who there were data waived practitioners. They're the ones that have the special designator on the DEA registration to prescribe buprenorphine products for drug addiction, detox, maintenance. And we were doing inspections on a lot of those clinics as well and trying to identify how they were operating, and if they were also writing within the scope of their normal practice or outside the scope, trying to identify those.
Great. And then another question we had come in is, how are distributors, manufacturers, or pharmacies regulated? Do they receive regular inspections?
Yes. Okay, that's a good question. So every fiscal year, it's written into the statute actually, and that's why DEA has diversion investigators, because we are required to conduct inspections on the places that are registered with DEA. And so we get what's called the work plan that comes on October 1st, and then we have an entire fiscal year to conduct what we call surprise inspections, and they're on a schedule, if you will. So we call them scheduled investigations. And so we will go into the manufacturers, distributors, importers, and exporters. Practitioners typically aren't on there because there's so many of them. We have recently added pharmacies on our work plan, and so sometimes those will pop up. But yeah, they're regularly inspected, and that's all part of us monitoring and maintaining that closed system of distribution.
Perfect. And then the last question that we had come in is, in the technician case, do you have any advice on preventing this from happening or how to detect this in our own facilities?
Yeah, honestly, I would give a lot of kudos to the pharmacist in charge who was monitoring the reports that she was running in the automated dispensing machines, because I think she caught it pretty early on. He had not been employed at the hospital for very long, and she was able to detect the access into that. And the fact that the automated dispensing machine was accessed using a fingerprint, I mean, it was we were pretty sure that that was the tech's, he was the one that logged on. He hadn't gotten like an ID number or a login, password to get in, and that could have been somebody else. So I think just, really monitoring what's going into the machine, what's going out of the machine, who's going into the machine, and just being vigilant of that was it's just a good technique to use. And then just kind of being aware, if you see something, say something. If you see a coworker that's acting kind of suspicious or fishy, report it to the supervisor or somebody else and just go, hey, there might be something up with that. Because patient safety is obviously the #1 priority.
Absolutely, and I think that's a really great answer. I know when I was practicing in the hospital, we had some patients that were diverting IV medications, and it was actually reported by one of their coworkers, and that's how they identified that individual diverting that medication. So great advice on this. If you see something, say something. I think that's all we have for questions right now. If there's any additional at the end of the presentation, I will bring Sarah back on. And with that, I would like to introduce our next speaker. Our next speaker is Jake Vogel. Jake is the Chief Pharmacist at Lloyd Veterinary Medical Center Hospital Pharmacy in Iowa State University College of Veterinary Medicine. He is also an adjunct professor specializing in prescription compounding at Drake University College of Pharmacy. Previously, he was the Chief Pharmacist and Operations Manager of Somerset Pharmacy in Ames. Dr. Vogel received a doctorate degree in pharmacy and a master's degree in business administration from Drake University. So welcome, Dr. Vogel.
Thank you, everybody. Nice to be with you today. Today I want to kind of go from a different angle than is pretty typical, I guess, from a veterinary medicine angle and an academia angle, because that's what I do every day. Here at the hospital, I'm at the Iowa State University Vet College. We are a hospital within the college. Essentially, what we are is a referral hospital. So if a vet or a private veterinarian has a case that's too big for them to handle, they'll refer it to us. We typically get 18 to 20,000 cases a year come through the hospital. We have 20 plus services in the hospital, so like oncology, dermatology, all these different specialties. Basically, the fourth year vet students rotate through our hospital in 2-week blocks and see these clients along with clinicians, resident doctors, intern doctors, and we service those prescriptions. We have 2 different licenses, a hospital license and a general pharmacy license, but most of our work is inpatient hospital pharmacy. Also, we have the academia side, but we have the research side on the college side as well, where we also provide medications. So we have a lot of moving parts. We do small animal, large animal, food animal, wildlife care in this facility. And basically the pharmacy, we have relationships with all these entities, and all of them fall under different rules and regulations. We have automated Omnicell service throughout the hospital. So all our controlled substances are locked up when they're not in use. We have 6 of them throughout the hospital in the different services, and then the internal one in the pharmacy. You can go to the first slide. The next slide, I'm sorry. So that's just a little bit of background of what I do every day. So defining diversion, the DEA definition over here, the transfer of any legally prescribed controlled substance from the individual for who it was prescribed to another person for any illicit use. My 2 big, populations that I have to be concerned about, since we have animals, our diversion relates back to the caregiver side. So the owner of the animal, the clinicians, student doctors, interns, residents, whoever, technicians, whoever's working with that animal. And then on the academia side and the research side, the researchers who are obtaining the meds to do research projects down on the college side of the facility. So those are my two big groups that I have to be concerned about when it comes to diversion issues within the hospital. And then when you talk about veterinary medicine, you have outside vet clinics too, and those private clinics, and I'll talk about that here in a little bit. You can go to the next slide. So, opioid medications commonly used in veterinary medicine. This is the list. It's a little different on some things, and then it's the same as you'd see on the human side or human hospital. We got hydrocodone, hematotropin tablets. That is basically the only hydrocodone tablets used in veterinary medicine. Fentanyl, you'll see fentanyl patches, and we have injectable for the hospital surgery units. In small animal, they do not use fentanyl. In large animals, so horses do not use fentanyl. When I talk small animals, I'm talking your dogs, cats, mostly dogs in the fentanyl though. Hydromorphone, again, small animal med used internally in our surgery units, injectable form is typically what you'll see. Demerol is not used a lot. We have it on this list. Methadone is another thing that we'll see in our small animal units, our surgery units. Our morphine, that is used in both large animal and small animal. So you'll see that in horses and dogs, cats, that sort of thing. Naloxone, Narcan, you'll see that a little bit. Butorphanol, you'll see a lot. Butorphanol is used in horses and in small animal. Probably the med that you'll see more in vet med than you would see on the human side for sure. And then also buprenorphine. Buprenorphine is also, both of those are partial opioid agonists that we'll come into contact with a lot and that we have to track and make sure they're used properly throughout the facility. You can go to the next slide, please. And then other medications that we use in vet medicine that, you know, are diversion concerns. Tramadol. Tramadol are typically sent home for pain management in dogs especially. Basically it's that and a fentanyl patch, but more, you'll see more tramadol than anything. So that is always of a concern to us. And ketamine is used in large animal, equine, horses, injectable, used a lot here. And then your benzodiazepines, midazolam, especially diazepam, we use here for internal surgeries, especially in large animal on those. And then alprazolam and lorazepam tablets, not as much, but you will see that occasionally, along with clonazepam for small animal use. Go to the next slide, please. So, the challenges we face here at the hospital and vet med, and that you'll see out in private vet practice, is veterinarians, unlike medical doctors, they still run their own dispensaries pretty much in most of their practices. You'll see that pretty much everywhere still. So essentially, they're prescribing, they're purchasing from wholesalers, and they're dispensing out of their clinics, but they are not a licensed pharmacy. They're just a practice dispensary. Those of you who are older, when I was a kid, I remember there were medical doctors that still did this before pharmacies kind of took that over, and medical doctors just became basically script writing clinics and diagnosis and that, and then would send off to the pharmacy. But in private vet practices, you'll see this it's a very common practice. Having said that, since they're not licensed with the Board of Pharmacies in these states, they are not subject to the oversight of those Board of Pharmacies. They do have DEA licenses, so they do have to comply, or if they're doing controlled substances, which practically all of them are, so they do have to comply with those rules and regulations. But as far as I'm aware of today, those private clinics still, they don't have to report to the Iowa Prescription Monitoring Program. And I believe that is still accurate. Sarah from the DEA, she can probably let me know if that's correct or not, but I do believe vet private clinics that are not registered with the Board of Pharmacy, they don't have to report to those programs yet. So that may be something in the future that maybe need to be changed. And then in vet practice, we use both human labeled products and veterinary manufactured products. I get that question all the time. What's the big difference between vet pharmacy and human pharmacy? Well, that's one of the big differences. Vet manufactured products are products that are only used in vet med. They have some different manufacturers, distributors. And one issue that we face continually on the vet side is many things like butorphanol, especially. Those packaging, especially on injectables, will be of larger volumes than what we use, because a lot of times they'll use them on herds out in, like, especially in large animal, in herds of food animal type animals, cattle, that sort of thing. So when we're using that for small animal, and we have our Omnicell automated dispensing machines, it becomes a little bit challenging on how we have to track everything and make sure that everything's being documented, issued, returned, wasted properly. So that can be something that we have to deal with and find ways to make work. Next slide. And then on the academia side, here at the college, challenges that we have and things that we have to figure out how to deal with. We have continual turnover of students, interns, residents, and researchers. I don't know all these people personally. It's a big college. So getting those personal relationships, I've always found, is very important when monitoring this. But each vet class, there's like 142 to 145 students typically. Interns come with us or come to us for 1 year. Resident doctors come to us for 3 years. And then researchers are kind of hit and miss. We're not sure. We're not sure. So that makes the job of building that trust factor and getting them into our system of how to do things and develop a continuity can make it challenging. Fourth-year vet students, when they're working through the hospital, well, you know, we want them to have the experience of controlled substances, but they really don't have the knowledge of, you know, the rules, regulations, and handling those. So through academia, that's something that we really have to stress to them and get them into the professional mode of dealing with. We have to let them get the experience of using them, but we also have to have witnesses work in groups to make sure that things are being done properly. And we try to avoid limit situations where individuals are using or administering controlled substances, especially in our student population. And then their limited knowledge, not only on the uses, but what each one does, until we get them in and get them going and they get some cases and get some experience. That can be challenging too, of when to use a med, when not to use it, what's appropriate for pain management. So in academia, those are some things that they're not DVMs yet, licensed, they're close, but they're not yet. So it's very important that we make sure that they all have an understanding of how this works and get them into our system. Next slide, please. So possible diversion signals that we look for, that we've had experience with and that have worked well in the past. High doses for patients, unnecessary quantities. Basically every controlled substance that is dispensed in this hospital for inpatient use, I basically go over, as the pharmacist here, every one of those records and match them up with the charges, the issue that return the waste every day in our surgery units, in our ICUs, to make sure that everything matches up and that everything was done properly. It is a big part of the job, and it takes a lot of work, but it's definitely been helpful for us to keep things the way they need to be. Not achieving a therapeutic effect, so as a result of opioid consumption by the patient. So shorting the dose, the prescribed dose, if the horse or something is not responding the way that, you know, it should be, that can be a red flag too. Who gave it? You know, we have witnesses, everything's been documented. Well, they're doing their professional duty. You'll see that where people will short the dose or not give the dose, even though they took it out and billed it. I'll talk about a case in a little bit where we had that happen a few years ago. inconsistent timing of prescriptions. Too often, you'll see them given or controlled substances in a manner in which is outside of the prescribing guidelines of professional judgment. And then no clinical reasoning kind of goes with that to prescribe the RX for that condition. So using a controlled substance in a situation, maybe with a dog or a horse for pain management that wasn't clinically necessary. And then no personal contact with patient receiving the prescription. This is a big hospital. We got a lot of clinicians, but every case that comes in is assigned to a team. So if you got a non-team member that is not familiar with that animal and is doing a lot of prescribing for that animal, then that's something I need to take a look at too. Maybe something, maybe nothing, but you always want to check. It's another flag. And then drug tampering, especially on the sterile products, altering the packaging, which Sarah was talking about there at the beginning. We've had that happen, and where somebody we had an individual refilling syringes of water and returning them to us, and that's how they were caught. I'll talk about that case here in a little bit. And then, of course, the drug diversion by students, staff members, clinicians, unusual activity by them, personal behavior, personal appearance, job performance, all of those things. And then the forgery of records, records keeping, charges, inventory counts, incomplete documentation. I really think that's the meat and potatoes of identifying diversion signals in a facility like this, especially. You got to get it documented. It's their professional duty. Things need to be written out, billed correctly, returned, wasted, and all that stuff needs to be documented. And veterinarians, I've found in my personal experiences that their level of documentation, it takes a little more, motivation from us to make sure that is done all the time, especially when you get in different sectors of like between small animal, large animal, food animal, that sort of thing. Next slide, please. So one thing I try to do, especially with the students that we get in, the new rotation students, new interns, new clinicians, we communicate right away. We don't let it be an elephant in the room. We take diversion here very seriously. We like open relationships, not just with them, but with our Board of Pharmacy and the DEA. We've had great recommendations from them in the past, especially the past couple of years, on things that we can do to improve and make sure that we're doing everything we can. We lay out to the students, so we have a zero tolerance policy. Don't let it ruin your career. I mean, and I've actually had, last year, I had a student, a resident doctor who came to us that had a diazepam addiction problem in the past. And after we had this initial meeting, she came up to me and she let me in on that information. And that was very helpful. So we made it for her, that she wouldn't have a relapse, talked about it with her, what makes her comfortable. And the honesty between the two of us has really worked well. So you'd be surprised how those initial meetings, when somebody comes into your facility, the effect they can have to help you out in trying to combat diversion. People, they want to do the right things in most cases. So that situation was kind of surprised me the first time, but I expect I'll probably have more of that in the future because of what's at stake for them personally in growing their career. And then facility-wide vigilance. Everybody in this facility, we stress it, not just pharmacy, but clinicians, interns, techs, student workers. Be on the lookout. When you're working with controlled substance, you pay attention to what's happening. And when it's in your hands and you sign for it, you're going to be responsible to answer for what happened to that med. So document and make sure that you're doing your professional duty when it comes to handling these. Next slide, please. So decreasing the opportunities, I talked about documentation is not an optional thing. It's your professional duty, especially students. They don't always have an understanding of that. After we have that initial meeting, they all have an understanding of that. Very important. Two-person teams especially here in the hospital when we got students working with technicians or students working with clinicians, residents. Very important that we always have two people. Our system is set up to basically, it would be very difficult for one individual at this point to divert within the hospital. Pretty much it would have to be a two-person operation. And I'm okay with that at this point. You know, until we have something happen in the future with two people, we'll address it when that time comes. You want to remove as much subjectivity as possible. I was going back to the packaging. You know, single-dose vials are great. Multi-dose vials, which we have on midazolam and ketamine, can be a challenge, especially in Omnicells, because all that information, what you take out and what gets put back in, has to match up on your reports. And on some of these ketamine vials we get, when they say from the manufacturer that there's 10 mils in there, well, there's not always 10 mils in those packaging. You know, they could be 10.025 or 9.85 that the fill was coming from the manufacturer. So that can become challenging too. But that's why unit dosed items, the more we have, the better. Single count items instead of having that subjectivity in there. Secure controlled substances at all times when they're not being administered with a documentation trail. So in the hospital here, we have those Omnicells. In our ICUs, we have cages for the animals that are in for inpatient, and inside that Omnicell, we have all their controlled substances. After they've been dispensed for that client, when they're not in use, they're locked up in that Omnicell. They got to do the fingerprint, the login with the witness to get them out. It just makes for a nice documentation trail, and it's really a good deterrent for diversion. And then we actually got this one from the DEA that we started to do this year. Investigate large quantity prescriptions, not just for inpatient, but for outpatient. So basically on those hydrocodones that we dispense, hematropins, and our tramadols, anything over 3 times a day, so basically any quantity over 90 for a month's supply or any 3-month supply, we are individually calling the clinician and verifying with them that that is what they want, and we document that on the script, that phone call. So we're doing that for every script that we have for controlled substance that is over a typical dosing pattern that we see. Next slide, please. So here's some of the things we do. We got the Omnicell over here on the left. The fingerprint works fantastic for how big our facility is. I don't know what we'd do without it, to be honest with you. For our individual draw-ups on syringes, we have these tamper tops, and tell you a little story about that. That was working great for a while, but I always thought these red tops could only be purchased by hospitals and pharmacies and medical equipment people with their licenses and presenting that, but that's not the case. You can actually purchase these tops online, and we had an individual do that and was retopping our syringes. So what we've done to combat that, after that incident, we now have a trademark tampered proof foil hologram. So it's got that hologram there and it has the Iowa State trademarked logo on there, and we wrap that around the top of every one of those syringe caps. So if you try ripping it off, it tears, so they can't be returned. If you try reprinting them, well, you're reprinting a trademarked Iowa State trademarked logo essentially, so you're going to have bigger problems. Or more problems than just the diversion. So we had to go to that level on individually dosed things because of the availabilities of these tamper-evident Luer lock syringe tip caps to the public. Since then, though, it's worked great. So that's just some of the things that we do within on situations like that. Next slide, please. So diversion attempts, incidents. I've had 2 here since I've been here, and this is coming up on year 7. What's an attempt look like? The first one we had an ICU technician who was a vet technician in our small animal ICU, was basically taking out 2 fentanyl vials and charging 2 to the client, administering 1 and pocketing the other one. Got caught on a records review on the charges. We basically reported it, and then the technician was confronted and basically admitted to it. And I think it traced back to in her life a while that this had been a problem, and that got reported to the Story County attorney, and she was brought up on charges, and I think she pled the case out, but obviously she no longer works here. And I do not know if I know her vet license was suspended for a time period. I do not know if she ever was able to get that back. She was using it for personal use, though. She was not redistributing, which was a good thing for her. Identify, investigate is very important. Once you identify it, you investigate it, report it. When I report, I got to report it to my hospital administrator, to central campus, or then it gets reported to the dean of the college. Then we get to report to central campus, and then the board of pharmacy and the DEA. And then that starts the investigation. We gather as much as we can. As a pharmacy, we turn over that information. And then, you know, if it ends up being something, then that typically will get turned over by those agencies to the attorney's office or the authorities, and then you let them make those decisions. The other case I had a 11th year of school, so a second year equine resident doctor, which is a great profession, very talented individual, was a resident that came up here and from out of state, was a great worker, but was taking our butorphanol syringes with those red caps and taking the caps off, the little 1 ml syringes, taking the 1 ml and then refilling those syringes with water, putting the cap on them and returning it to the Omnicell. What tipped me off on that one quick was his records keeping was poor. He was taking out of the machine and returning a lot of items, which is odd. Doing that and this is in large animal for horses, taking out for horses that many times is a little atypical. And then these syringes are sterile syringes. We could actually started to see, you could actually see that the syringes that weren't just quite right. So what we ended up doing, I basically got him into a machine that he was logging into that no one else would have used, and he put those, returned those syringes. I sent those syringes off to get tested, and they tested for no drug. They were water, and we turned that over, and he basically lost his residency and was removed from the program, and the authorities did press charges, I believe, and I believe he is under probation. But as far he still can be a licensed vet, but as far as getting in a resident internship program or a resident equine surgeon program, he'll probably never get in one again. That's a pretty select program. So, and it was over just a few, you know, butorphanol is a small amount of, it was a very small amount, but it was a huge consequence for his personal career. And again, from that face-to-face meeting, I gathered that this is a problem that extended back to, you know, he had some medical, like a back injury or something in his teenage years, and that's where it all started. So those are the two situations I've had to deal with. Thank God, no more than that. Especially with younger individuals coming in, first timers in their career, it's a different situation. You do everything you can to prevent the diversion, but going forward, I tell the administrators all the time, there's no guarantees that I can make you that, somebody's not going to try something. But those are some of the things you see in vet med. The regulation over the years in vet med, every year it gets a little tighter, especially on those private clinics. You're starting to see more and more regulation. So next slide. Does anybody have any questions?
Perfect. Thank you so much, Dr. Vogel. I think you hit on some really key aspects of diversion and how to recognize it and prevent it in your facility. I'm also really impressed with the relationship that you had with that resident who had a history of substance use disorder, and not only saying, hey, we're trying to prevent diversion, but you're saying you're trying to help her not relapse. I think that's absolutely incredible. And then the other comment I had is that you are correct that vets are not currently reporting to the PMP here in Iowa. I believe the first state that made that a mandate is New York. So that is the only one I'm aware of that is currently having veterinarians report to the PMP. So the one question that we did have come in, question is, on the veterinary research side, how do you ensure these are used for studies and not diverted elsewhere?
Okay, so and this is actually good. That's a great question because with the help of the DEA, we actually got a better understanding of this. They've been doing things down research for 30 some years before I ever came here, but nobody really knew what the expectations were. DEA researchers actually they do not have to be clinicians, so they don't have to be licensed vets to obtain a research DEA license. So they can get a research DEA license for like Schedule 3, 4 meds and acquire them from us and not be a clinician. Typically, a research they fall under what is, I don't want to get deep into it, but the IACUC rules, and that's where they get their grant money and everything from, and they have very detailed documentation they have to do for IACUC. So they are technically, the hospital and the college are separate, so they are kind of outside of us, but they use their DEA licenses to acquire them from us. We give them an invoice now, and then it's under each individual's DEA license, and now they are responsible for those, to use those in those research areas, and they have to document those, everything for those IACUC reports, and then whoever's overlooking the head of the research down there is responsible to make sure all those IACUC reports, everything is filled out, just like I am for everybody here in the hospital. So before, they had one researcher that was using one DEA number to acquire all the meds, which that's the DEA was not going to go with that, and was a good thing. They came in, and we have changed it so every individual researcher now has to get their own DEA number under their name, and once they acquire the med from us, and we give it to them, then it is on their DEA number, and they're responsible with those IACUC reports on that research side, and they're the overseer of the research to make sure those documents are done correctly for their IACUC reports and their research use for the grant money or the federal government or whatever, or state government, whatever project they're doing. It's very important. We also have them for individual. So if they have a lot of mice they're working on, we actually will sell that as it's patient specific, so script specific to those animals now too. So it's not just for, they can use it on whoever they want. Whatever they get from us, it is specified for that project for that animal, and that's how that is documented now. So I'm very comfortable with it now, how we have it set up, and again, that was due to having open conversations with the DEA, especially, and the Board of Pharmacy, but more so the DEA, on the expectations of how we need to have this done. So I highly encourage that to all pharmacies, especially, is to have an open relationship. I mean, practically 99% of everybody wants to do things right, but you need to know what the expectations are to do them right. So that's how we've handled that.
Thank you. I think that provides some great insight on having that relationship with the DEA and making sure that you kind of cover all your bases when it comes to that potential, especially in that specific situation with research and not having necessarily the administration aspect of it from your hospital. So that's the only question we had come in for Dr. Vogel, but we will take any other questions you have at the end of the presentation. And now I would like to introduce our next speaker. We have Dr. Bob Russell with us. Dr. Russell is a public health dental director for the Iowa Department of Public Health. He started his dental career in a rural health center focusing on migrant farm workers, and later served as the dental director of Hackley Community Care Center, a federally qualified healthcare center in Michigan. Dr. Russell attended Loyola University of Chicago School of Dentistry and received a master's degree in public health from the University of Michigan School of Public Health. He's earned a certificate in public management from Drake University. And with that, I will turn it over to you, Dr. Russell.
Thank you. First slide, next slide, please. Once again, we see the definition of drug diversion, and I think we're pretty much familiar with that at this point, so let's go to the next slide. And what I want to talk about and focus on a little bit is the unique environment of the dental practice. Dentistry, for the most part, is still practiced as a solo provider profession. Those are the majority of dentists. There are, of course, group providers and other types, but the majority, almost up to 90% of dentists, are in small solo-owned practices. And those solo-owned practices present unique environments where problems with diversion of medications can be a little bit different than what you might have in a large organization where they have safety protocols in place and ways to monitor drugs. For example, in small dental practices, there are still some that do not use electronic record-keeping systems. There's still some that use dispensing or prescription paper pads, as well as keep their records that are handwritten rather than computerized, which means, of course, there's the issue of clarity of the written notes, how much is written down, things like that can become gaps that can allow certain things to transpire that can basically escape detection. So let's talk about a few of those kind of things that can show up in a dental practice. For example, dental practice may have on-site opioids. In a case like an implant practice or periodontal practice, you may find that they might dispense directly from the practice site, or they give an injection for a patient after the procedure in order to give them immediate comfort, so when they're dismissed, they're not in acute pain. Most of dental practices deal with acute pain, which means an incident like surgical event or something of that nature, infection, which creates pain that they might prescribe an opioid in those cases, but very few prescribe them for long-term cases. We're talking about maybe 7 days, maybe a little less or a little bit more depending on the outcome of the procedure. But one of the big risks is that prescription pad abuse. It's very possible, and I'll talk about a little bit about an example of that a little later on, but that prescription pad of a provider might have been diverted and used to basically order drugs that the provider's not even aware of. So we'll talk about that in a little later. And in those cases where there are electronic records, those electronic records might not be secured. It may be a very simple system, in which case they can be altered. If those records can be altered, once again, it will open up the door for abuse. Then again, since it's a small practice, you may have a single dentist with a few staff supporting that dentist. The dentist, in order to keep volume going in the practice, might delegate prescription authority writing to a staff member rather than directly write it themselves. Once again, opening up the door where a prescription pad or entry might be falsified by that staff person. And then, of course, there's an excessive number of pills for acute pain episodes. Even relatively recently, the ADA released a general guideline to say that a dentist should not prescribe more than 7 days of opioid medications. So that is the new position that the ADA is taking to try to slow down the excess use of opioids. But in some cases, there might be a situation where, like the frequent refills. You might have a person who comes back periodically or very frequently saying they're not getting any relief from the pain. The dentist conscientiously want to help that patient feel better, so they might prescribe an additional prescription, and this might go on for a while. So it depends on the situation. And then, as I mentioned, there's also this is the practice variation that maybe the stronger opioid is used than necessary. Maybe the hydrocodones rather than the Tylenol 3s, or even an oxycodone, depending if the provider is used to using drugs of that strength level for those kind of routine surgical situations. That's not recommended, but sometimes that does happen. And then there are doctor shopping patients. Now, I want to talk about this a bit because this is an experience I had as a clinician, and I'm sure others have had it too, where a patient actually goes from practice to practice, presenting with a clinical situation, that is maybe an abscess around a tooth, and actually has an x-ray taken by the earlier provider that they actually bring to the visit in your particular practice. And the x-ray could be years old, but they just keep it on themselves whenever they go and say, hey, doc, I got this issue. And you look at the x-ray and you look at the mouth and you might actually say, wow, there may be an issue here. So you give up a prescription and then they immediately go to another practitioner and do the same routine. Unless there's a means to capture that, once again, the doctors are really looking at what they consider a legitimate clinical situation, but not necessarily knowing that the patient is simply just shopping for the antibiotic for the pain medication. And then there's the other aspect of being a solo practitioner, is it's isolation. Providers in solo practices tend to be highly stressed. It's very hard to keep up with the volume of the work as well as by yourself. And sometimes there's just that opportunity for diversion of medications for self-use. And so that in itself can become a risk within adult practice. Next slide, please. And there are other things that can actually lead to abuse. Once again, I mentioned the small practice budgetary restraints, reluctant to invest in internal RX security controls is one thing. It's a small budgeted practice when there are changes like regulations that say you need to do these particular steps in order to improve your safety in your practice concerning drug control, they may not be done simply because it would be a cost. And that cost involvement, well, it's prohibited to the practitioner in order to take on that cost, so they just don't add those particular internal securities. And then there's the on-site drug dispensing I mentioned earlier. The fact is that if you are dispensing drugs on site and you are actually a dispensing organization, now as a dentist, you should basically apply for a dispensing license if that's what you're doing, separate from just prescribing. So that record should be available, unlike the veterinarians that we just heard earlier. But however, as I mentioned, it's not wide practice, but it is done on some occasions where there might be dispensing of medications on site, which allows for abuse. And then there's another factor that we haven't talked about so far, and that's the desire to please the patient. Once again, if you have a small practice facing budgetary restraints, you want to build your practice profile where patients come to you, you might be a little bit more flexible about giving medications to the patients, especially if they demand certain medications, just so that you keep the goodwill of the patient. So they come back and additional money and treatment is done. So it's a temptation. I'm not saying it's something that's widely done. I do not believe it's widely done, but I do believe that it can be a temptation in a given small practice. And then there's also just being conscientious of the patient's pain and attempting to eliminate 100% of the acute pain the patient might be experiencing. Now, it's not realistic to think that one can actually get rid of 100% of pain. There's always a certain amount of pain that might break through. Doesn't necessarily justify going to a higher level of narcotic in order to try to give ultimate relief. However, that is a risk factor, and that can be done. And we talked about, in a sense, sloppy security, inattention, and trust. And I want to talk about the trust factor. One thing about being a small practitioner and having a small cadre of workers working with you is that environment requires trust. You develop that trust usually over a period of time so that you're not really suspecting that anything is going wrong in the practice that you don't have eyeballs on. And therefore, those abuses can occur without you even aware of it. And so sometimes we can be a little too trusting if we don't put in types of protocols that allow us to double check whether or not what we think is happening is truly happening. And then there's the whole idea of provider isolation, stress, and addiction. Next slide, please. And these are extremes conditions. And I don't know, I won't say that every practitioner addresses it the same, certainly not. But this is just examples of what might become a temptation to a practitioner to prescribe a certain way. For example, patients claims only a specific non-generic brand name says say medication works, or they're allergic or unresponsive to others. These are constant claims. The prudent practitioner, of course, would be a red flag immediately when they say, I can't take generics. That should be a little bit of a concern at that point. However, that does happen. Or they say they're allergic, and without questioning whether or not a true allergic response has been experienced, uh, then once again, you don't want to give them something that's going to trigger an allergic response. However, you might want to validate through testing whether or not that is actually true before you would change your prescription pattern. Or if they say they're unresponsive to other generics, for example, well, that still may not justify that you give them something stronger because they're not responsive to a particular brand or a particular type. Each of these should be flagged to the provider to be very, very suspicious. However, on its face, you might basically do these things in order to appease the patient's concern. A provider relative. I mean, how many providers have not had relatives who ask, well, I got this pain, and would you please give me something for that? And they write a prescription for that particular relative without questioning whether or not the relative might be selling those medications or diverting them in an illegal way. So that's another risk. And then there's poor surgical outcomes, because obviously the best of clinicians can do a great job in a surgical situation, and yet the healing can be complicated, especially in the mouth. One of the problems in the mouth is I have to say it's a relatively dirty place. And food and different debris gets in the mouth after the surgical procedure has been done, and it can actually complicate the healing process. And the patient, instead of saying maybe they are somewhat responsible for the fact it's not healing well, they'll take their anger out on the provider. And sometimes the provider then, to quell that anger, will give them a higher medication or narcotics in order to get them out of pain and hopefully appease the patient until the healing actually does occur. So that can be a risk factor. And there's just the fact that some dentists are reluctant to confront patients showing potential addictive tendencies. So they might actually sense that something is wrong, but they don't want to make the patient angry and they don't want to lose the business. So they don't immediately respond when they think, when their suspicions are aroused. And so the abuse can continue for a period of time. Next slide, please. So those are basically the situations, but at the same time, I would like to talk about a few cases that I have encountered and those of my colleagues have encountered over time that might be significant. I've witnessed a practice where it was a large practice in this particular case, where actually a prescription pad was diverted by a worker who basically took the signature line of the doctor, because when you use a pad of paper, you leave an indentation in the pad, even though you might remove the top prescription and give it to the patient. That signature line might still remain. In other words, it's not in ink, but it's legible. The person could come along and actually trace the signature of the doctor in the pad and then write whatever they want. And so having open pads that are available, like sitting on a counter or at an operatory chair, that can become a risk factor because it could be diverted by an employee who's very good at just writing in the letters of the indented script signature. So that's one example that did eventually result in that particular employee being arrested for that particular situation. So that's one example. And of course, if you have on-site medications, there's always a possibility a staffer might divert the medications for self, especially if those medications are not monitored, the dosage and amount aren't tracked, and there's no record. That makes it all the more easier for those kind of abuses to occur. And every now and then, pharmacy techs, or not techs so much as salesmen, will come to the office and talk about a special new opioid drug that they'll give you a few samples just to try it. And sometimes that can become a source of addiction to the provider or to a staff member on site. And so these are just a few examples, but these examples are quite real. And so there's a number of things that need to be done. And obviously, dental practices need to upgrade their safety protocols and their electronic record monitoring systems where they don't use pads, for example, for prescribing. It actually use an electronic system that actually cannot be altered. that would be very helpful. Those are things that are certainly are coming to pass. But just to keep in mind, there's still quite a number of small rural practices out there that still practice and techniques that you might consider probably 20 years out of date. And just because of the smallness of the practice and then the budgetary limitations, these practices do not necessarily take on the new modernization that is necessary to avoid these risks. So I just wanted to bring that to your attention. Thank you. Is there any questions?
Thank you very much, Dr. Russell. I do think that dentistry has a very unique impact on the opioid crisis, especially with the way that you described, so that independent practice and all of those pieces. So I think that was very helpful. I have not seen any additional questions come in at this time. If you do have a question, please use the chat function and feel free to put that question in. I know that this is a really unique topic and something that is very important for us to be aware of, not only the dentistry practice, the veterinary practice, but also how the DEA is helping with this opioid epidemic here in Iowa and across the nation. They're doing some really great work. Again, I am not seeing any questions come in at this time. So I did want to remind everybody of a couple of webinars we do have coming up. Our next webinar for the project is going to be our final webinar, and that will be on May 3rd. This will focus on patient-centered care, monitoring, and disposal. We are fortunate enough to have the Board of Pharmacy join us to talk about the prescription monitoring program and the update that was made last week, as well as an update from them on how we can dispose of our medications and what that looks like here in Iowa. So be sure to join us for that one. And then our final training webinar for contact hours will be Addiction Identified, Now What? And we have a speaker, Dr. Gustala, who is in Marshalltown and works with medication-assisted treatment, and will provide us some information on referrals, what medication-assisted treatment is, and some of that work there. So definitely looking forward to having you all on those two upcoming webinars. Again, if you do have any additional questions or if you need any assistance with the project, please feel free to reach out to myself or Lana. Our information is here on this slide. And then a reminder that to obtain nursing contact hours, you must have entered your nursing license number at registration, must be logged in individually with a unique email address to the webinar for the full duration of the presentation, and then a nursing contact hours certificate will be emailed to you in the following weeks. There's also the opportunity to receive a certificate of attendance if you are not receiving nursing contact hours, and for that will be sent out again in the next couple of weeks with that completion information. I do want to do a big thank you to Dr. Russell, Dr. Vogel, and Sarah for joining us today. I think this was a great informational webinar, and a lot of great things were shared to help us combat diversion within our own healthcare facilities. And just a reminder that if we do see something, we should say something. I hope you all have a great rest of your Thursday, and we will talk to you on the next webinar. Thank you.